From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, joined as always by Dr. Jim Salwitz. Dr. Salwitz, lovely to see you again.
Chris, looking well, sir. It's another lovely day in the medical neighborhood, as you're prone to say. It is truly winter.
Yes,
So cold.
it's, January, they were saying how warm it was. And, I don't think it ever got that warm, maybe one day in the 50s. But, compared to average, definitely way above average. Now, all of a sudden, February, winter has decided to arrive.
Yes, indeed.
We'll take it.
So I'm bundled up, by the fireplace with in a sleeping bag, and that's as far as I'm going for the next few days. Your patients can come to me, I think.
Well, and speaking of finally arriving, the phase 3 data from Johnson & Johnson released late last week. The Johnson & Johnson vaccine candidate, 66% overall efficacy worldwide, 72% efficacy in the United States, and 85% effective overall in preventing severe disease. And, it did show it is effective at reducing hospitalization, reducing death. And importantly, it did show it is effective against this new strain that we're seeing coming out of South Africa, the B.1.351 strain of the virus. So that is important. Maybe not the huge numbers, certainly not on the level of Moderna or Pfizer that people were hoping for, but still enough to be a game changer. Yeah, no, it's important. And plus, we'll get large numbers of vaccines out there quickly. They have the manufacturing capacity to produce billions of shots. So I think it's critical that this piece and stuff. I think people are going to be pretty reassured, excited, and I think also there is some little bit extra comfort with the technology that was used to develop this particular vaccine. I'm not sure I'm certain that's not warranted, but it is a reality. So people may be more willing to take this vaccine, which will make a significant difference by itself. True. And of course, the more people we can vaccinate as fast as safely possible, the sooner things can start to return to normal. Everybody wants to get back to the way things were 18 months ago. I don't think we'll ever get fully back there. I think the world has changed, hopefully in some ways for the better because of this. Certainly one of those things that people want to get back to, having all the schools back open, all the students back in the classroom. And with that, I'd like to introduce our guest for this week's episode, Dr. Lawrence Kleinman. He is the Division Chief of Population Health, Quality, and Implementation Science in the Pediatric Service. Dr. Kleinman, thank you so much for joining us. You are one of the nation's most recognized voices when it comes to COVID-19 in kids and in terms of schools. So thank you so much for joining us.
It's my pleasure, Chris. Jim, so good to see you, and you're very kind in your introduction. Thank you.
We enjoyed having you here in the spring talking about schools and everything. I think people learned a lot from that, so we figured it was important to bring you back. Not only that, of course, you yourself had some good news. Before we get into the good news and the exciting stuff that you're starting to work on, I recently learned that I think you actually grew up in New Brunswick.
That's correct. I grew up in New Brunswick, and I'm a Rutgers alum for undergraduate. And then after a long time in the diaspora, I'm thrilled to be back home.
That's interesting, because it's interesting how it combines, thinking about your personal life, your broad interest in populations as a whole, in communities under the stress caused by problems with disparity and diversity, and you come back, so you personally come back to the community in which you began bringing this broad view into now a system that has maybe finally come around to your way of thinking, if you will, and is very interested in these broad theories, broad ideas of population.
Well, I think it's very exciting to see it happen. And maybe I share an anecdote. When I was leaving Rutgers, there was a young firebrand in the community named David Harris, and he ran something called the Neighborhood House. And David and my mother were close allies in advocating for the needs of poor in the African American community in New Brunswick. And David's gone on to be a Board of Governors member and president of the Board of Trustees of Rutgers University, and now is still running a daycare, mostly caring for Latinx children in the community in New Brunswick, still doing wonderful things. But the reason I bring David up is that when I left New Brunswick, I said I'd be back someday to try to do some good in this community. And he said, we'll see if you ever come back. And I always held that as a challenge. And shortly after coming back, one of the first people I reached out to was David, to take him to lunch and both to say that I was back and here to try to do good, but also to thank him for putting that out front and explicit. So I always had it as a part of my life goals, was to get back and be working in this community.
That's a fantastic life journey and cycle, and I just hope that we haven't disappointed you in preparing the community for your return and the platform on which to continue to build.
You're very kind, Jim, and I'm thrilled to be back. And New Brunswick has changed so much, and yet so many of the fundamentals are the same. It is a city with and about its people, and I'm amazed as I'm in the hospital and I discover people who grew up not far from where I did, who are turning their efforts and their careers towards giving back and towards trying to make this truly a healthcare city for all.
Well, that's very exciting. We are thrilled to have you back. So one of the reasons, actually the first reason we wanted you back, other than just your great wisdom in what we're dealing with the COVID, is the grant, the NIH grant for which you just received, which is exactly at the core of everything we're talking about. So congratulations on that. That's pretty exciting. Do you want to explain what the grant is and what you're going to be working on?
Sure. Well, we're very fortunate. We are one of 8 sites in the country to get this first group of child-focused grants in this NIH program to study and look at COVID. And the purpose of our work is to try to understand which children are at highest risk for getting sick from COVID, not just having the virus, but having the virus and needing respiratory support, ICU care, or perhaps getting better in the short term and then getting this later illness known as MIS-C, multisystem inflammatory syndrome in children. So we took a different approach to it, and it's interesting and appropriate that you highlighted community, because we felt that probably most people who were going to get these grants were going to focus on the immunology of COVID-19 or SARS-CoV-2, the virus that causes COVID-19. And what we did was we included a piece of that, and we took advantage of some of the amazing talent at Rutgers. Marilla Gennaro, who is one of the leads of the Public Health Institute, is at New Jersey Medical School and is a part of the broader coalition known as New Jersey ACTS, which is an NIH-funded research infrastructure, is overseeing that part. But we also wanted to think about what does it mean in the community? What about the social determinants of health? What about behavioral attributes, policy attributes, mask wearing or no mask wearing? So what we have done, in addition to thinking about what's going on in our community, is we've created this large network of networks around the country to be able to bring in cases and to bring in data so that we can examine all of these factors. We can look at the immunology. For a small group of kids, we'll have the money to look at the genetics of it. But for all of them, we'll be thinking about social determinants, some in terms of looking at national surveys and data that's readily available, some in terms of actually asking the families, and the limitations are simply by what we can afford. But we're going to really try to take a very broad perspective, bringing different types of data together to understand this illness and how it comes into a community and who gets sick in the community. And once a child is sick, who goes on to get really ill and who's going to recover without long-term consequences.
At a gross level, at the highest level, I mean, do we have some feeling about the percentage of kids that are at significant risk?
It's small. Whether it's 1 in 1,000 or 1 in 100 or 1 in 10,000 might depend upon how you articulate it. but we're talking about unusual or rare diseases when we talk about MISC. We're talking about uncommon when we talk about acute respiratory pneumonia or perhaps some of the gastrointestinal symptomatology that COVID can be associated with. We think it can sometimes mimic appendicitis and perhaps at times even cause it. These are early observations that we're still learning about, but we're thinking about how to predict the needle in the haystack in order to either identify populations for whom the risk is so low that we don't have to invest as much clinical resources and anxiety and worry for those, or those for whom it's so high that we really ought to be taking extra precautions even beyond the things we're already doing.
You know, it's interesting. There's been several articles that have been written saying that 2 years from now, one future of COVID-19 is that the entire adult population has become immune either by vaccine or by post-infection, and that this has become an endemic infection on a day-to-day basis in children, kind of like it would be like a common cold, the thing that's in your from school with, the fever. So we won't even think about it in general as adult thing. We'll have transitioned beyond that terrible passage, but it will be common in children. And the reason I cycle back to that is what you're describing kind of reminds me of Ray's syndrome. You know, when you start thinking about a common disease, the flu, that actually heavily damages a small set of children for a reason we never knew for years, and was critical to predict.
I think what you frame is a very interesting perspective. I hope we don't end up with that circumstance.
Okay.
My concern is that we actually don't know the long-term consequences of this illness. And I'm concerned that the long-term consequences and serious sequelae, serious consequences that follow downstream may be more common than the shorter-term illness. There may be a lot of children who get a mild inflammatory reaction, but that sets them up for future disease. I think that we have from the beginning had our set point altered by the early reports that children were spared and not at risk. And I think we have interpreted everything that comes out with kids with that favorable expectation. And yet, actually all of the data points, or virtually all of the data points, have been on the worse side than our expectations, rather than the better side. So I'm really worried about this. I'm also worried about thinking about our return to normal in the summer or fall with 300 million adults vaccinated and the children not yet vaccinated. I think that's a very bad thing, and I'm here to put out, in part, to offer a cautionary note. We're already seeing early in the pandemic, I predicted that one of the consequences potentially for children was not only the physical outcomes, but the emotional outcomes of either rightly or wrongly perceiving themselves as the vector by which adults in their environment get sick and, God forbid, might die or have serious disease. And we're seeing that happen. There was a story in USA Today about that recently. A friend of mine, was a friend of my wife's, was talking to her today about her daughter who brought it into their family, who was going to go to talk to a mental health professional because she's feeling overwhelming guilt, even though everybody did fine. So I think that still waters run deep, and the kids are the still waters, and we don't know what's running under the surface. And so I think we have a long way to go. I'm very eager for the vaccine trials in adolescents to be completed and in the younger children to be undertaken, and for us to vaccinate the kids as well. I think the emphasis on getting the schools open is both important and fraught. And I think we've dealt with the important part, but we need to be more explicit about the fraught. How do you consider an outcome where the typical consequence is a benefit, maybe even a large benefit? So the average child benefits from school being open, but a small number have devastating consequences. How do we think about allowing children in certain circumstances, living circumstances, or people at risk in their family, or perhaps those who can't get the vaccine or on immunosuppressive medicines for whom the vaccine might not work, and allow them the opportunity to opt out of the normal experience and still integrate them into the community? I think these are the under-discussed aspects of where we are right now. They're getting lost in some of the optimism and excitement of the light at the end of the tunnel. And that light is great. And I fully support immunization. I think that adults who don't have absolutely compelling reasons not to ought to be immunized. That being said, I don't think that gets us all the way through the tunnel. It gets us deep into it, but we have to take care of and protect the kids as well.
With other viruses, we learned a lot by longitudinal tracking. Papillomavirus, EBV, particularly in the oncology world, etc. So, is this study going to be setting up a group of kids to be tracked longitudinally?
I hope so. So this is currently what we're doing. We're partnered with Bristol Myers Squibb Children's Hospital is partnered with Maria Ferrari Children's Hospital in Westchester County to recruit a group of children who have already had the illness, who we would like to follow. And we'll be able to follow them for a short time. We will need additional money to follow them for a long time. I actually hope that we'll be able to add some of the other hospitals within the Barnabas system. One of the challenges is data access and data sharing. We are a big and diverse system, and we have to figure some of these things out. But I will offer that opportunity to other institutions, and I hope and expect that at least some of the other children's hospitals will participate with us. And then we'll get a few people from these various networks. We have the Children and Youth with Special Healthcare Needs Network that's located in Denver. We're working with the Pediatric Rheumatology Consortium, which is largely an East Coast group of hospitals organized out of actually Hackensack Meridian, with whom we're very closely partnered in this work. There is a pediatric clinical trials network known as Spectre 2.0 in Kansas. There's the Pediatric Research and Inpatient Settings Network, which is hospitals all across the country, between 100 and 200 hospitals. There's the American Academy of Family Physicians National Research Network. There's the Dartnet Institute, which is private, not-for-profit. Full disclosure, I'm a non-paid member of their board, with whom we are partnered. We also have partnered with a number of data resources through a relationship we have with Metro Health. So the Epic Corporation has a large data set. There's a tremendous amount. Family Voices, a national organization of families of children with special health care needs, to keep the families at the table as we're making decisions. And with all of this, we would really like to do analysis in the here and now, analysis looking backwards at what's occurred before. That's called a case control study. And then follow them over time. The NIH is committed to 2 years of funding, dangled another 2 years of funding out for us, for which we are not guaranteed, but we're very hopeful and optimistic. And then actually, with grants like this, there's the potential to get what are called supplements that might keep the work going over time. So we are trying to do just what you described, but we're taking it one step at a time and trying to meet the NIH where they are right now as well.
I think, again, going back to your own personal journey, it's and how this all connects, the system thing. When you think about this catastrophe, the COVID-19 as it affects society, but you think about our system's response to it. This is really the proof in the pudding of why we went to the great work of bringing together these institutions, both the hospitals and the clinics and the doctors, but also the medical school and all those connections, and moving this together to be able to respond medically, but also study this. And then I think the next step when we're all on Epic 18 months from now, you'll be able to sit at your desk, hopefully not too socially distanced by that point, that we can actually be next to each other, and you'll be able to punch up and go, how many kids in this system receive this and how many have these problems? And then many of the institutions you just listed are already on Epic. And there, it's interesting that this is the first major test of this system, and it's, the broad possibilities of what we can do. It says really incredibly exciting things about the challenges in the future, and of course our ability to deliver for our communities, which goes back to which things that are so important to you, to the system, and to the state itself.
I love how you put this together. I think that the system very rapidly coordinated itself, and around children specifically, which I'm more familiar with, although I've seen it in the adult world as well here, in order to deploy resources thoughtfully, concentrate the development of expertise in a few places early on, and then disseminate that out. And also with the partnership with Rutgers, bring and identify and obtain informed consent from patients that we can use their data to learn. That learning can drive our clinical performance, but it also then can contribute to the broader knowledge. And at the end of the day, it means that RWJBarnabas Health and Rutgers can sit as national leaders, as thought leaders, in ways that neither could do it alone. One of the opportunities has been for us to contribute to other national work. We contributed and participated in the first study of children admitted to pediatric intensive care units. That was published in JAMA Pediatrics, a very prestigious journal. And then we helped to stimulate and move another national network to start to look at MIS-C and get many of the cases from the metropolitan area into a larger database funded by the CDC. That was published in New England Journal, probably the most prestigious American medical journal. And then because of that, the press started to come to us to ask questions about the articles, about the illness. And so we are now out in the media, and we are go-to place. It's a rare week that I don't get at least one inquiry from either a regional or a national outlet to ask something about what's going on with schools, with kids, with vaccines, with teachers. And hopefully it's through these kinds of experiences that the different cultures of academia and clinical healthcare delivery can integrate into a synergistic whole that is much greater and much more powerful and much better able to serve our community and our field than either alone.
From your lips, Larry, that's where we're headed. That's what we can build. It's fantastic, critical work at a critical time. And we are deeply appreciated for what you're doing and for your leadership. And I'm very excited to see what we learn from this in the next couple of years.
Oh, thank you. I'm very excited to be back home and doing it here, and to be doing it with you and with the others at Rutgers. Kudos to Sally Radowick, our chair 100%. In pediatrics, and also to the leadership at RWJBarnabas, and also their recognition of the importance of this partnership with Rutgers and of the leadership, the academic leadership at Bristol Myers Squibb Children's Hospital, which I think is very important. It's a full service, full thickness children's hospital, and I hope that it will go from this tertiary quaternary care institution to one that's able to provide even more of the highly specialized care that then feeds into the opportunity to do research, that feeds back into the opportunity to do care better. And it's that virtuous cycle that really is the vision and the opportunity we are all trying to make come real.
Absolutely.
Dr. Larry Kleinman, Division Chief, Population Health Quality and Implementation Science in the Pediatric Service here at RWJUH and at Rutgers RWJMS. Thank you again so much for the time and the insight, and congratulations on this grant.
Thank you, Chris. Thank you, Jim. I look forward to being able to speak with you another time and share our results, and also to learn from the two of you, as I always do. Thank you.
Thank you.
Always insightful conversations here that we get to have on Medically Necessary and really highlight the unique and incredible academic programs. In this case, really being able to marry academics and that community health vision that the system has. And of course, I have to mention that, and I have to mention the fact that we're now into February, which means U.S. News and World Report season is coming upon us. So if you have not already received an email telling you that you can go ahead and log into your Doximity and vote for U.S. News and World Report's top hospitals, keep an eye out, because if it's not already in your inbox, it will be soon. Usually about a 1 month time span to vote on those. And that's really an opportunity to recognize not just the incredible academics that go on here, but the commitment to quality, the commitment to top level patient care that we have here at RWJUH and throughout the RWJ Barnabas system. So really a strong opportunity to take advantage of that and recognize the work that is done. And as always, you can subscribe to Medically Necessary on all your favorite podcast platforms. We're available on Apple Podcasts, Google Podcasts, Spotify. We have a playlist on YouTube, and you can always access us through the Robert Wood Johnson University Hospital Medical Staff Portal. For Dr. Jim Salwitz,
Chris Hoenig.
Thank you for listening.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.